Good afternoon, everyone. It's my first time at ISOT, and I am actually a bit awed by the presence of so many senior and also not so senior transplant physicians and surgeons. But our chairpersons are a very friendly and a very relaxing lot, so thanks to our chairpersons for keeping me cool. My topic is fun, and good afternoon, President Madam. My topic is hygiene and hormones. Now, can we live without hygiene? Whether you're a transplant surgeon, a transplant donor, or a recipient, or none of the above, can we live without hygiene? That's a question. It'll be difficult. Can we live without hormones? It's just not possible. You cannot be born without hormones, and throughout life, you need hormones for each and every aspect of life. Especially if you're in transplant medicine, the term that we use is transplant medicine, but just think carefully. As a nephrologist, what are the drugs that we use? Either you're using hormone blockers or you're using hormone agonists. There is hardly any medicine in nephrology which is not linked with hormones. So it's important to talk about hygiene and hormones, and it's in the fitness of things that we begin with this topic. I'd also like to commend and thank Professor Saurabh Sharma from New Delhi for having coined the concept of metabolic nephrology and having spearheaded that. But coming to our topic now, we all have transplant patients. We know that getting the transplant done is just the first step in a very long journey. After transplant, it is that medicine which is even tougher. And I would also like to thank all of you. My mother-in-law, she lived with the transplanted kidney, a non-related one, for 11 years. And thanks to all the nephrologists who took care of her. She's no more now. There are multiple challenges that a transplant recipient faces. One of them is infections, specifically UTI. There are multiple risk factors. Two of them are being a woman and old age. There is no definition of old age now, but women are actually now a gradually increasing number of kidney transplant recipients. And they have multiple challenges. One of them is UTI. They are at high risk of UTI. If they develop a UTI, it's going to be a recurrent UTI, and it can be a refractory UTI. So this is a challenge. How do we handle them? How do we handle these patients? We have to understand the pathophysiology. Apart from all the other renal aspects that are there, you think of urethral health, for example, you think of the upper UTI, there are also other aspects of the pelvic floor, the pelvic musculature, the other systems. So vaginal health is important. And a question to the younger boys, I'm very sure you all know the pH of the urine. So is there anybody who doesn't know the pH of the urine? Okay, there's nobody. So now the question is, what's the pH of vaginal fluid? And let's look at the smart boys and girls at the back. If you're blank, that means you don't know. 5.5. Okay, so is the pH of the vagina higher than the pH of urine, or is it less than the pH of urine? Less. It's less, yeah, it's more acidic. The pH of the urine may not vary with age, it may not vary with gender, but in women, the pH actually varies. The point we want to say here is that as a nephrologist, when you say that the acidic pH of the urine prevents against UTI, it prevents against infection, that is even more important for vaginal infection, for vaginal fluid. Vaginal fluid is more acidic than urine. Unfortunately, the pH increases as age increases in a woman, and the post-menopausal vaginal fluid will have a similar pH to that of urine. So we should be aware of this. This is one aspect. The other aspect is about microbial diversity. So pre-menopausal women have a different kind of flora, both urinary and vaginal, and post-menopausal have a different kind of flora. This is irrespective of whether they have UTI or not, irrespective of whether they have had a renal transplant or not. So the microbiome is different. The vaginal microbiome is different in pre-menopausal women as compared to post-menopausal women. These are aspects of physiology that we should be aware of. Unfortunately, we don't discuss them. That is why when somebody comes in with an adjuvant therapy for prevention of UTI, then sometimes we feel that that's just quackery. So again, speaking to the younger people in the house, one should know the normal pH of urine and also the normal pH of other body fluids. Out of syllabus question, what's the pH of saliva? Shabash, well done. President ma'am, we should be proud of all the boys and girls. Maybe we can give a clap for them. This everyone was able to answer. So coming to the fact that we need to, jo bhi bola theek bola na, even the chairperson also didn't know, so it's okay. So hormone therapy, my topic is hygiene and hormones. So we come to the first aspect, which is hormones. Now estrogen deficiency plays an important role in the pathogenesis of UTI. That is because estrogen contributes to the integrity of the epithelium, not only in the urinary tract, but also in the genital tract. Not in the genital, but also the urinary tract. So the epithelium becomes stronger if estrogen is adequate. Secondly, estrogen modulates immunity. So if estrogen is adequate, you will have a proper, robust immune response. If estrogen is deficient, immune response will be inhibited. And this leads us to therapy. So from the physiology, we understand pathology, and then we can move on to pharmacology. If you can harness the strength of estrogen to improve the urogenital tract health, anatomy, as well as physiology, you may be able to prevent recurrent UTI. So this particular study assessed 5,600 participants, all women, with a baseline UTI. And what they did was they wanted to assess whether one prescription of local estrogen therapy could prevent infection or not. Look at the cohort, it was women who had had a baseline UTI. So in community medicine, you read about primary prevention, secondary prevention. Here this was secondary prevention. The patient had already had a UTI. We wanted to see whether we could prevent another episode of UTI. And what they found out was that over 12 months, they were able to reduce the risk of recurrence of UTI by 52%. So giving one course of local estrogen therapy reduced the risk of recurrence of UTI by 52%. Now just compare that with the results you would see with phosphomycin or with long-term nitrofurantine. Any day, the vaginal estrogen therapy is more effective. Not only does it reduce recurrent UTI, it also improves symptoms. It improves well-being. It improves quality of life. And then this study tried to find out which are the women who benefited more actually. The ones who had a higher risk of UTI, the ones who were elder, the ones who had diabetes, who also had associated urinary incontinence, these are the women who required the drug more and who benefited more. There is a catch, however, there is a caveat. There are animal studies, there are preclinical studies which show that if you give too much of estrogen, you might end up reducing the immune response to candida. So we should be aware about the fact that bacterial infections are different and fungal infections are different. The immunity involved in managing them is different. But now we come back to our topic. We have learnt about physiology. We have learnt, there is a problem and we should give estrogen. But can estrogen be given just like that to anybody? What do the gynecologists think about it? What do the endocrinologists think? So the answer is menopausal hormone therapy is a very safe and secure method of management. But of managing whom? Earlier, this is 30, 40 years ago, it was thought that estrogen was the panacea for everything. So it was thought that estrogen could be given for primary prevention of cardiac disease, cardiovascular disease, primary prevention of osteoporosis, bone disease, skeletal disease as well, musculoskeletal disease. Then studies came in which showed that no, it's not effective as a primary prevention for cardiac disease or a primary prevention for osteoporosis. And because of misrepresentation of that study, MHT or estrogen replacement therapy went into near oblivion. But now we have a balanced viewpoint. If you have a person with menopausal symptoms, if you have a person with estrogen deficiency, then the treatment is estrogen. So anybody coming in with hot flashes, vasomotor symptoms, the treatment is estrogen. Anybody coming in with what we call genitourinary syndrome of menopause, GSM, urogenital atrophy, dyspareunia, burning in micturition, any kind of symptoms related to the local GU tract, the treatment is estrogen. If you want to give systemic estrogen will give you higher levels of estrogen that can predispose to hormone-sensitive cancers, endometrium, breast. So then you have to investigate more, you have to monitor more. However, if you use local estrogen, if the complaint is only local, it's atrophy, then you can give a local estrogen. Now another quiz question. Estrogen is a women's hormone. Is estrogen found in men? That's a question. Yes or no? What is the rough level? A premenopausal woman, will she have the same estrogen throughout life? That's a question. The answer is no. Shabash. Yeah. So it will change. The estrogen in a premenopausal woman is very low in the early follicular phase. Then it becomes very high when ovulation occurs. And then it comes down, but in the luteal phase also it remains higher. So there are ups and downs. When you give local estrogen, you bring the estrogen level only up to that lowest level of the follicular phase. So the estrogen level in a woman who is taking a local estrogen cream will be the same as that in a person who is not taking estrogen cream. The systemic level is not going to change. What this means is you don't need to monitor too frequently. Also, there is no worry about cardiovascular or cerebrovascular risk. So it's a very safe drug to use. Whatever issues you read, they are related to systemic estrogen therapy, and they are related to very high levels of serum estrogen. Estrogen creams are available. In our setup, we use non-estrogen creams. So quite frequently, we prescribe Lubic gel, which you would use for your catheters. But this is a gel which helps in quality of life of many men and women. We also use lip balm. So somebody is complaining of loss of integrity, and then issues about hygiene, we'll talk about that later. Instead of using Vaseline, you might want to tell a postmenopausal lady, why don't you use lip balm? And that will give you better vulval health. So try that. We also use a phytoestrogen known as Purifica. This is economical. In case we are worried, we are not able to do a proper baseline investigation, it happens many times in practice, we use this. But otherwise, my drugs of choice are Evolon cream and Primarin cream. Very easy to use. You have an applicator, you tell the patient to apply it. Do note that the estrogen receptors are most dense in the lower part of the vagina, in the lower 1 inch. And the entire length is around 4 inches. So there is no point in going high up till 4 inches. There is no point in touching the cervix. You just go beyond 1 inch and that will suffice. I come from one of the most conservative states of the country. And when I went into endocrine practice, one of the toughest things for me was to take a menstrual history. So I used to look at the ceiling and take a menstrual history. Now I have kind of become better, and now usually if it's a young lady, I look at the mother and ask the girl her menstrual history. So at least I've reached that level. I don't have to, because you know there is this geriatric spine syndrome and also things like that, so I had to take care of my health also. But it's not very difficult. Even I am able to explain how to take it. The dose is also very simple. You tell the patient to apply daily for about 2 weeks, and then once or twice a week thereafter. And you will find that the quality of life is much better. Of course, you should take a history. Whatever standard of care is, you should be able to rule out hormone-sensitive cancers, which are breast and endometrium. CA cervix is not hormone dependent. CA cervix, if at all, is infection dependent. And pap smear is not a routine treatment for postmenopausal care. It's not a routine standard. It is just part of standard. The preventive pap smears should be done thrice in a lifetime, in a woman's lifetime, and they should all be premenopausal ideally. So it's not a major issue. Even if you are in a setup where you are not able to access gynae care immediately for all your patients, you can prescribe for a few weeks. If you feel there is a confusion, does the patient have UTI or GTI, genital tract infection? You have to take the history. Bathroom करते हुए जलन होती है, bathroom करने के बाद जलन होती है. That is a simple question that you can ask in any language. दर्द होती है, does it pain? खारिश होती है, does it itch? These are more towards genital tract infection. All vulvovaginitis is not going to be infectious also. It can be trichomonal, it can be fungal, it can be anaerobic, but it can also just be chemical because of SGLT2 inhibitors. It can be just because of poor hygiene or itching. So you just ask the lady to change her choice of underclothes. It can be chemical because of the shampoo or the deodorant that she is using. So you ask them to change that. In such women, the lip balm will work very well. So a personalized approach is required. Depending upon your gender, if it's the ladies there, depending upon your age, how comfortable you are, you may wish to take the history yourself. If you're not comfortable, you just put a few questions and you train your receptionist or your nurse to ask those questions. But you will be really, really rewarded with happiness. The patient will actually come back feeling happy. Whenever you prescribe any hormone or any biological for that matter, this black mnemonic is what we use in endocrinology. Talk to the patients about the benefits, the limitations. So when you use vaginal estrogen, the quality of health, you will feel just you've become younger again. You will not have dyspareunia, you will not have dysuria. Limitations, this does not replace an antibiotic. If your doctor advises an antibiotic, you must take. If the urine culture is positive, you treat according to that. Adverse events possible, hardly any. However, you should go for a gynae checkup, get a pap smear, get a mammography done. These are routine parts of life. Contraindications, hardly any except for hormone dependent cancer. Cost, minimal, 500 rupees, which will last more than a month actually. And knowledge required, yeah, you need to know how to apply. So that much we have to teach you. Can we use, can IOCT come to a consensus? Can we use vaginal estrogen as an adjuvant therapy to prevent UTI? So primordial prevention, perhaps not. Primary prevention, perhaps yes. But secondary and tertiary prevention, certainly, this is a drug that is important. If patient has active fungal infection, you treat that first, then you go to the estrogen. But otherwise, there is no major contraindication. We also have newer levels of prevention, which I'm sure that senior members of the house have not read during their college time. So quaternary prevention means we are enjoined not to overdiagnose, not to over-label, and not to over-treat. So do not label any woman as having a recurrent UTI until she fits your diagnostic criteria. And do not label everybody as having genitourinary syndrome of menopause until they actually have the symptoms. But for genitourinary syndrome of menopause, the limiting factor is taking the symptoms. It is history taking. What is the quality of my history taking? Am I able to make the patient feel at ease? What is the quality of the patient? Is she able to share everything with me? Two limiting factors, and the third limiting factor, the ambience. I may not want to share personal detail with you if, let us say, my sister-in-law is with me, or maybe my spouse is with me. If you are judgmental, and if the question is asked in such a way, do you have these symptoms, and I get a feeling this person is asking me about sexually transmitted disease, I will not share. On the other hand, if I am asked in a non-judgmental, non-sarcastic, in an empathic manner, then I will share my complaints. This is in stark contrast to everything else that is there in organ transplantation. Everywhere else we are biologically based, we are numerically based. You look at the numbers and then you decide what kind of immunosuppressant to give. So here it is the importance of history taking. History taking will tell you whether the lady has got GSM, genitourinary syndrome, whether she has got hot flashes or not. So this is something we have to revisit, and we do not need to refer to an endocrinologist for this. We should be able to do it ourselves. That is quaternary prevention. Do not over-treat, do not over-diagnose. And quinary prevention is most important. That is what we are all engaged in today, and I would like to thank ISOT leadership. Quinary prevention means preventing misinformation and promoting information. So we keep with a lot of pride and with a lot of happiness, we see that IOCT is growing by leaps and bounds. So thank you, madam, for preventing misinformation and also promoting information amongst all medical specialties. In hormones, we have spoken of estrogen, but testosterone is also there. So like you rightly said, estrogen is there in men, but then testosterone is also there in women. 50% comes from adrenal, 50% from ovary. And after menopause, testosterone levels come down. There is a role for giving testosterone also, not for recurrent UTI, but for women who complain of hypoactive sexual disorder. So as transplant recipients live longer and longer, you will find that these issues will crop up. And the good transplant physician is the one who is able to handle all these issues as well for the patient. If you feel comfortable, do it yourself. Otherwise, you refer. But you can give testosterone in very low doses, in one-tenth the dose of men, to women as well. However, testosterone replacement will not impact lower urinary tract symptoms in women. Now, we've spoken of hormones, but my topic was hormones and hygiene. So we come to hygiene as well. Hygiene is related to the microbiome of the vagina. We've already mentioned that the pH changes in women with age. The pH is more important in the vaginal fluid as it is to the urinary fluid, to the urine. But urine is sterile in a healthy person. Vagina, saliva, they are not sterile. So we have microbiome. These microbiomes they are happy bacteria, they help, provided that they are diverse and healthy. But as menopause approaches, the diversity goes down, the type of bacteria change. So that means a probiotic that a gynecologist may choose for a premenopausal woman will be different from what she will choose for a postmenopausal woman. Whether they are helpful or not, whether they are not harmful or not, that is open to conjecture. We actually don't have very good quality data. But there is good data that simple things in hygiene, like hydration, regular urination, not holding your bladder for too long, these actually help in preventing UTI. So simple things for personal hygiene, and you should be able to explain to everyone. Yeah. Sure. Wash using a neutral soap, wash from front towards the back, simple things that you can tell. If you don't feel comfortable, you put a leaflet in your OPD and give it to everyone. Newer and newer challenges are coming. So tobacco, alcohol, hard drugs, if all this substance abuse was not enough, intravaginal tobacco is a new kind of a drug abuse, which we should be aware of. If you have not started, please do not start. If you have started, please stop. If your partner is doing, please stop. But self-management is important. And avoid activities, we are all aware of these common sense things, but if ISOT could prepare a standard document which we could use in all our clinics, this will help everyone. Which are the outdoor activities, which are the activities related to sexual activity, which are those related to simple hydration. And again, I learned from Dr. Saurabh, hydration beverage index, beverage hydration index. So like in endocrinology, we have glycemic index, we have beverage hydration index. This is something that should be part and parcel of nephrology and ISOT and organ transplant practice. Women do all these things themselves as well. So what is the harm in telling them how to do it properly? So we must teach them about shaving, use of proper beverages, beverage hydration index, spices and foods. Here I will come to something called comfort spices, comfort foods. These will vary from place to place. In Haryana, for example, I would say, aap lassi zyada piyein, drink more buttermilk. This is cool. Patient will be happy. In Konkan, I will say, drink more kokum juice. So whatever comfort spice, comfort beverage, some spices we think are hot, others are cool. Aap ilaichi dal ke lein pani mein. Patient will accept that. So again, coming to levels for consensus, hygiene, whatever we have, primordial, primary, secondary, tertiary, for all these levels, hygiene is important, but we should be able to standardize these. If we can standardize all this, we will be able to help our patients, their family members, and the country and world at large. Thank you.